Hello guys, can you hear me? Can you see me? A very good evening everyone. So myself Dr. Ranjith. I'm a pathology educator at Unacademy. So here we are with one more session. Week and I couldn't complete the two sessions, so I thought that we'll do it today and tomorrow on the subsequent days so that we can fill in the gaps. Right? So I'm sure you must have known about the Unacademy QBank challenge, which is going on from August 5th to August 9th. There'll be 15 questions, 15 minutes. We mix it back from almost various subjects possible. You can enroll to that with the link below this video description, as well as it will be in the chat box. Fine. So attend it whenever possible, and 50 of you, yeah, that's 50 of you, will have chance to win the Unacademy Light subscription. Fine. Okay. So to go through it, and I hope this will help you to ace your NEET PG exam. We have put in lots of clinical questions here. We have vertically integrated it and made sure it's a very balanced QBank, so it will help for you as a learning as well as a testing too. Fine. So there's a doubt clarification going on, and there are specific batches to cater your needs. If you're a plus subscriber, you can go ahead and enroll to whatever you feel like. If you're not a subscriber, you can go ahead and get the subscription as well. Use any code, whatever you have, or you don't have one, you can use Pathocom. Right? So today, let's start today's discussion. So I'm going to do the same thing. I'm going to display you a question, comment on the answer, and then let's discuss something related to that. Right? It's a very simple one. I've got 4-5 questions today. We'll discuss it, keep it short and sweet, and then we'll see tomorrow again. Okay. Any comments? What do you think? I'll mute myself for next 30 seconds. Comment on the answer. Okay, Sachin started with A. Anyone else wants to add to it? I know it's a pretty simple question. It was a PYQ. I just wanted to start it on an easy note and a better note. We'll definitely discuss the question, how to arrive to a diagnosis and everything. Tanishk has gone with A as well. Fine, great. Okay, so let's read through the question and see what could be the possible answer. And most of you have answered the right one, right? Great. Neetu has gone with B and majority of you have gone with A. Fine. See, I'm not going to take in all these inputs because these inputs of CA125, LDH, CA199 is something which is volatile. Because if I base my diagnosis on a tumor marker or any fact, there is a chance I might miss it, right? So let's take little bit information into account with the help of the image. Let's try to solve the question and then we look at the other options as well. Fine. It's a 30-year-old person and this is post-surgical. So obviously it's a gross image of an ovary. I'm going to ask you a few leading questions. I want you guys to answer that. Fine. Looking at this gross image of ovary, I just zoomed it. Just tell me whether it is a solid structure or it is a cystic structure. I just wanted to keep it very, very simple. Solid or cystic. That's more than enough for me to solve this question. It's a cut surface of ovary. It's been cut and open and kept into two halves. So it's a solid structure or a cystic structure. It's undoubtedly a solid structure, right? A potato cut or whatever it is, it's solid structure. So this information is more than enough for me to solve a question, right? Now let's go through the options. We'll look at the microscopy also. We'll go through the options. We have dysgerminoma, I have teratoma, papillary serous cystadenocarcinoma, and choriocarcinoma, right? These are the 4 options for me. If you remember teratoma, you always use a term. Teratomas are called as mature cystic teratoma, isn't it? If you remember or if you imagine seeing teratoma's image in your pathology department, you'll have a cyst-like structure with tooth and hair projecting from it, right? So if it is teratoma, it has to be a cystic mass only. Even in an ultrasonogram, even in radiology, teratoma will have heterogeneous areas. It's not homogeneous at all. Teratoma undoubtedly is heterogeneous and undoubtedly cystic. So I can easily rule out this option. Even without reading any history, even without having tumor markers, I can rule it out just with the help of appearance of a solid structure, right? Second, when you have any tumor, keep this in mind. This you can generalize for every tumor throughout the body. When you have any tumor which has the term serous, it will be cystic. Because serous means it's a secretion, right? Serous secretion. If a tumor can secrete, obviously it will form a cyst with fluid inside it. That's what we term as serous. A serous cyst. A synovial cyst is a serous cyst, right? Warthin's tumor, serous cystadenoma lymphomatosome, will be cystic. Any serous tumor in my body will be cystic because it has serous secretion inside it, right? So this also is ruled out for me just by looking at the gross appearance of solid nature, right? Let's go back to the gross appearance again and let's see if I can decipher anything little bit more from it, right? I'm zooming into the gross appearance again. Tell me, this appearance, is it homogeneous or hemorrhagic? There are only two informations I'm asking you. Is it homogeneous or it's having areas of hemorrhage? Where will you put it? Homogeneous or hemorrhagic? Again, I want you guys' inputs. We can learn a lot just by the appearance of the tumor. It's undoubtedly homogeneous, right? I'm not having areas of hemorrhage, right? I'll come to it, Sachin. Maybe you are pointing out as areas of hemorrhage to these areas, the tiny, tiny ones in the corner. It's mostly homogeneous, right? I'll tell you why some of you are thinking of hemorrhagic. If you look at this image, again, carefully watch the image. Can I say that I'm just putting dots here? Can I say that this dots, whatever I'm circling, is the tumor mass? This tumor mass, whatever I've circled, that's perfectly homogeneous. This rest of the part where you guys felt it's reddish in color is the normal ovary. When I'm going to have a tumor, will the normal ovary get compressed and congested? It can. So that's a background normal ovary. That's not the tumor for me here. So this part and the outer half of it, this part is the tumor here. So this tumor per se is definitely homogeneous, solid appearance, right? Let's go back to the other option. Do you think, is it possible on earth to have choriocarcinoma which will not be hemorrhagic? What is the origin of choriocarcinoma? What tissue does it come from? Does it come from epithelium of the ovary or it comes from your cytotrophoblast and syncytotrophoblast? The origin of choriocarcinoma is from your syncytotrophoblast and cytotrophoblast, right? It's a placental tissue. Undoubtedly, any placental tissue will be hemorrhagic in appearance only. It will be completely reddish in color, right? So since I'm having a completely homogeneous mass, I'm not going to call it in choriocarcinoma, right? So choriocarcinoma also ruled out. So just with the gross appearance of image, I have only one option left, which is dysgerminoma. It is solid, so I can rule out teratoma and serous tumors. It is not hemorrhagic, it's homogeneous, so I can rule out choriocarcinoma, right? I just want you to keep in mind because sometimes it might come in an exam and you might miss it, fine? So let's say I'm having a specimen of choriocarcinoma. Choriocarcinoma is a bit more common in the uterus compared to the ovary, but anyway, when I have any gross image of a choriocarcinoma, it will be very, very hemorrhagic and blood rich, right? So blood rich tumor on long term, the blood will get altered, right? So what will be the color? Will it be bright red in color in a stored specimen, or will it become your brownish to blackish color? Any hemorrhagic tumor on a long-term storage, will it be still be red in color, or it will become brownish to blackish color? It will undoubtedly become brownish and blackish in color, right? Perfect. So I want you to remember that. The reason why I'm telling you to remember this is, do not think it's a metastatic melanoma. Because for me, I'm hardwired in the brain. When I see something dark brown, and if first option is melanoma, I want to diagnose something very exciting, I go and choose that, right? So if it is a brownish lesion in the uterus or in the ovary, think of choriocarcinoma first and then melanoma. Melanoma is an extreme rarity. But if the question says there's a skin lesion which is diagnosed melanoma and this is an ovary, yes, I'm going to go for melanoma, right? So it's based on the history. Keep in mind, it'll be brownish because it's altered blood. Fine. Okay. Let's go to the history. So we know the diagnosis just with a few pointers from the gross finding, right? So now looking at the history, I'm just zooming it here. A 30-year-old female came with abdomen pain and adnexal mass. I don't have any leading points there. CA125 and LDH are marginally elevated. And just one more, I'll just erase whatever I wrote here. I want you to comment on CA125. Is CA125 diagnostic of a malignancy? Yes or no? CA125 is it diagnostic of a malignancy? We'll take CA125 because this is very important for you guys when you come to practice. It's not for an MCQ. It's not diagnostic of a malignancy, right? Perfect. CA125 is a marker, that's all. It may be elevated in cancer. I'm not denying the fact at all, right? CA125 is never diagnostic. It will increase the suspicion, that's all. CA125 can be elevated in simple endometriosis. It can be elevated in many benign endometritis. It will be elevated. Benign tumors, it will be elevated, right? So in lots of condition, it can be elevated. I have a cutoff. If it's like thousands, 2000s, yes, I do think it's malignant. Again, it's a suspicion, right? It is not diagnostic. That's true for every tumor marker what we have. None of the tumor markers are diagnostic. It will increase the suspicion. But can I say a CA125, can I use it for prognosis? Can I use it for a prognosis? I've operated a case of, let's say, any random ovarian tumor. Can I use it for prognosis? Yes. Any tumor marker for me is prognostic. Which means, let's say that it's a case of granulosa cell tumor. and you have removed it, CA125 automatically comes back to normal. Again, on follow-up, if it increases, I have to remember that, okay, there's some other metastatic deposit or there's a recurrence there. It is never ever diagnostic, right? I'll go back to the question again. So I have one more option of LDH. What do you guys think is the utility of LDH in an ovarian or a testicular lesion? We'll compare both ovarian and testicular together because most of them match together. What do you think, or where do you think you will LDH help? Thank you, Zaki. Where do you think LDH will be useful in case of an ovarian or a testicular tumor? Perfect. Right? The LDH also has no role in diagnosis. LDH will be elevated irrespective of whatever tumor it is. The only equation about LDH is if LDH is elevated, the equivalent is it's a big tumor. That's all. It's just the mass. If I'm having a 1 centimeter tumor, the amount of LDH elevation will be less. If you have a 15 centimeter tumor, the amount of LDH will be more. It is not diagnostic. LDH elevation will not separate germ cell tumors from non-germ cell tumors or seminomatous tumors of testis from non-seminomatous tumors of testis. It's just like Gulshan said, it's a mass effect. That's all. It will be elevated anywhere. Like Mikito said, I will use LDH for myocardial infarction also. That's a totally different thing. Or can I also say, can I use LDH for a diagnosis of a hemolytic anemia? Is that true? Can LDH be used for diagnosis of hemolytic anemias? Yes, I can do it as well, right? So I can use LDH for diagnosis of hemolytic anemia also. In other words, LDH will be elevated whenever there is cell death. It's as simple as that, right? It's equal to cell death. When LDH dies, when cell dies, LDH will be elevated. So bigger amount of like 10 centimeter tumor, I naturally expect more cell death compared to 1 centimeter tumor. That's what it determines. As simple as that. LDH has no diagnostic role. Only thing is, it tells me a cell is dying. So bigger the tumor, more elevated LDH is, right? We'll go back to the question, right? CA99 is not elevated, right? I have one more information which is there in the question about CA99. Can anyone tell me where do we use CA99? Is it useful at all? CA99. Any tumors where you think CA99 will be elevated? CA99 will be elevated in case of, sure you know that, be elevated in case of pancreatic carcinoma, right? Perfect. It's a tumor marker for pancreatic neoplasm, right? So here I don't have any problem here because I'm having an ovarian tumor. CA99 is not going to be much of help for me, and obviously it will be normal, right? And the below is the gross and the histology image, right? We know about the gross. We diagnosed almost everything from the gross. Let's go to the histology. Let's see if I can diagnose something with the help of histology also. It's a very, very classical appearance of a dysgerminoma or a seminoma. Both means one and the same in female and the male counterparts, right? So let's go and dissect the image into tiny, tiny bits where I can identify few things. Okay, I'll circle few areas. Tell me what color you see predominantly there. I have only three colors in histopathology. It's either your pink, blue, or clear. Fine. If I'm going to circle this area, I'll mark it as 1. You're just going to learn from it. Can I say in the first area we circle, I'm seeing lots of whitish color or clear areas? Like you guys said, fried egg appearance. Am I seeing the clear areas? Definitely you're able to see the clear areas, right? Okay, second part. Let's assume that this is the second part. In this second part, what's the predominant color you are seeing? The yellow one, or what are you seeing? It's pink or clear or blue? In the yellow circle, I'm predominantly seeing bluish color, right? I'll just write bluish for here because I'm sure you will agree with me. I'm seeing more blue color. Here, I do have clear color, right? Okay, third one. Can I say or can I draw something? Uh, I have a line here, right? Can you see the thin line here? A thin line here, a thin line here. So it's not complete, but you can see from the center, there are few radiating lines, right? I will remove the line, whatever I drew, just see it, carefully notice, there'll be a very thin line seen there, right? I'm having thin lines, which is radiating from this part, right? Okay, I'll redraw that line again, right? So that these are the three important components of diagnosis of a teratoma or a seminoma. It's both one and the same, fine? The first thing for me is the appearance, right? Let me erase this. Escape. The first thing for us is it will be divided into septa. I'll have a very, very thin septa dividing the tumor cells. And like you guys said, I'll have tumor cells which will be surrounded by a very clear cytoplasm. That's what you guys gave a naming of a fried egg appearance. For me, more important than the terminology is what makes them clear. We'll come back to it soon. And along the septa, if you noticed in the center, we had lots of blue dots. These blue dots are the lymphocytes, right? First is my fibrovascular septa, separating the tumor cells, making them having an organoid appearance. Second, you'll have lymphocytes in the septa. Okay, that's also very important for me. And the septa should be there. And third, I'm going to have clear tumors, right? I'll have definitely clear tumors. Right, let's look at the clear part. Tell me whatever comes to your mind. What all substances will be clear on a microscope? Miki told me the answer, but still I do want to hear from most of you guys. What all substances are possibly or will be clear in a microscopy? Answer is glycogen, like what Mikito said, but I want you to think through it, not just jump into the answer. One, it can be water, it can be lipid, it can be mucus, it can be glycogen, right? These are the different possibilities which can make a cytoplasm clear. And here, the reason for the clear cytoplasm here is it's glycogen. Let's little bit go back and see why am I having glycogen? Because there are only few tumors which can have glycogen, right? Not many tumors will have glycogen. What is the cell of origin for your dysgerminoma? What do you think is cell of origin? Is it an epithelial tumor or a germ cell tumor? Where will you divide them? If it's dysgerminoma, you will call it an epithelial tumor or a germ cell tumor or a Sexcott stromal tumor or a metastatic tumor. I want a basic question for us to understand the glycogen part. It's a germ cell tumor, right? A germ cell is a very, very fastly dividing cell. Yes or no? A germ cell divides very fast. Yes or no? It'll obviously divide very fast, right? That's a property of a germ cell. So when I'm having a tumor which grows very fast, automatically I don't have an interface. I don't have an interface so that I cannot use or store my glucose and needed for the cell division during interface. So since a tumor is dividing very fast, I'm having glycogen stores in the cytoplasm so that it can divide again. It can divide again. It can divide again. It keeps on growing. Right? That's the reason the glycogen is seen in the tumor cells. It need not be always completely white in color. You can have pinkish color also. It's totally depending on the storage of the glycogen. Very dense glycogen storage, it becomes clear. Less glycogen storage, it becomes pink color. Right? It's nutrition dense tumor. That's right. Okay. So these three things are important for me. Like you guys said, it's glycogen. See, when you read some question, I want you to foresee what can be the question in the next exam. Right? Only I can even attend a new question. It's not just that I have to attend the old questions only, right? If it is glycogen rich tumor, can I say seminoma or dysgerminoma will be positive for a stain which stains glycogen? And what will be that? Abakashi, I'll answer you just a few seconds. What stain will be positive for glycogen, which can be easily demonstrated in this tumor? Perfect. Right? So I can give you a hint saying that it's an ovarian mass which was PA is positive, or a testicular mass which is PA is positive. Your answer should be either dysgerminoma or seminoma, because this is a tumor which will have abundant stores of glycogen. Right? Great. Right? It'll be magenta pink in color, a dark shade of pink in color. Right? Okay. Actually, fish and flow cytometry are two different tests. When I want to know genetics of a tumor, I go for fish. When I want to know expression of a tumor, I go for flow cytometry. Let's take with an example. Let's take acute myeloid leukemia, AMLs. If I want to diagnose whether it is AML M3 or M4, I go for flow cytometry because I need to know whether it's myeloid or monocytic. That's lineage. But when I want to know translocation 821 or translocation 1517, I do fish, right? As a basic difference between fish and flow cytometry, one will tell me the genetics, one will tell the protein expression, right? Right. Okay, we're done with the first question. Let's go back to the second. Go to the second one. We'll learn. It's a very, very simple basic question. Read the question and I want you guys to comment on the answer. I'll mute myself for 30 seconds. Just a brief thing, there's an Unacademy QBank challenge. So the link is pinned in the chat box as well as will be there in the description below. Do attend the QBank challenge and you'll have a stand to win the entire Unacademy light. Okay, Tanishq, get started. What? It. Fine. So we have many of you have gone with D, right? So I don't think so. There is no difference of opinion between you guys. Most of you have answered option D, right? We'll read through the question. We'll try to read something new in the. It's a very simple test. It's a very very basic question. I'm sure you know. We'll try to extrapolate few things based on this basic science, right? A 56-year-old alcoholic admitted with diagnosis of pneumonia. Primary care physician orders a test which will identify the speed of sedimentation, right? Okay, of the RBCs. In other words, the person is testing nothing but ESR, the erythrocyte sedimentation rates. Which of these will be the mediators will be responsible for that? And you guys said it's fibrinogen. Obviously, it's fibrinogen, right? We'll understand why fibrinogen is important and how can I extrapolate it to other findings which I'm sure you must have read in your hematology, fine? So what happens is RBCs. The RBCs are very, very tiny. But the volume of RBCs, what I have inside my body is humongous. I have close to 4 millions and millions of RBCs per ml of blood, right? Per cubic mm. It's very less, but huge amount, right? So it's a very huge amount. What happens is these RBCs has to be repelled from one another. If they are not repelled, they all will coalesce together and my blood can never flow, right? So what happens is I'm going to have a charge. I'll have equal charge on the RBCs. This is inside the body. Okay, this is inside the body. They'll have charge so that it will not sediment during a flow. Otherwise, it will definitely sediment. I'll have lots of complications because of that. But when I'm going to keep it outside in a test tube, that's what we do basically in ESR, right? When I do in the test tube, one component which goes away is the flowing blood. The flow is stopped. It's standing column of tube. When it's standing column, this RBC surrounding them, I'll have plasma. The plasma has obviously all the clotting factors. One of the important one for us here is fibrinogen, right? Okay, I'll have fibrinogen here. This fibrinogen will neutralize the charge in a standing blood. Once the charge is neutralized, all the RBCs come and settle the bottom. This is what happens. And the charge which is given by the RBC, which is neutralized by the fibrinogen, is called as zeta potential. If you have an MCQ on a very basic science, they might ask this. Okay, it's called a zeta potential, right? Okay, this is what happens in ESR, fine. Now let's go to the pathology here. If fibrinogen levels are going to become more in the blood, am I right in saying that the RBCs will settle faster? Is that statement right? The level of fibrinogen in the blood is more. Will the RBC settle faster? It will settle faster, right? So if it settles faster, the erythrocytes sedimentation rate, that is ESR, will automatically be elevated. That's very simple equation. So whenever I'm going to have a very increase in fibrinogen, the sedimentation will be very, very fast. So I'll have an increased ESR. So this is what we see in every inflammatory condition. When there's an increase in fibrinogen, ESR increases. And fibrinogen, as we know, it's a simple acute phase reactant, right? So whenever an acute phase reactant is there, it increases, right? If this statement is true, increased fibrinogen increases ESR. Can I also say that in pregnancy, ESR will be elevated? Is this statement right? Pregnancy is a normal condition. Will there be increase in ESR? Obviously, right? It's not just in inflammatory conditions. One is for me inflammation. Every time inflammation in my body will increase ESR. It's also a physiological condition. In pregnancy, that can be more ESR, right? So if you are interpreting ESR in a pregnant woman, first don't do it. If you're still doing it, it can have till 100. It can completely sediment, right? The rate of sedimentation can be so fast. So it will definitely confirm the clinical diagnosis. ESR is not something which will be helpful in pregnancy at all, right? Please don't go ahead with ESR in pregnancy, especially close to third trimester. It can go to 90 to 100, even sometimes more than 100, right? So we'll ignore that during pregnancy alone. Right? In other words, any disease which increases fibrinogen will definitely increase ESR. Or in other words, will have more zeta potential blockage and will cause RBC sedimentation. Let's say, have you heard about this interleukin? Since we are post-COVID, I'm sure most of you guys will know about this interleukin, right? Am I right in saying that interleukin 6 is something which will also be elevated in inflammation? It's also kind of an acute phase reactant. Yes, right? So what happens is, in reality, interleukin 6 is the one which increases it. Fine. I'll come to it. Just give me a second. I'll come to it, Mikito. Just give me a second. Right? If interleukin 6 is more, it'll increase fibrogen. That causes ESR to sediment, right? That causes more ESR, right? So I'm having a tumor, which is myeloma. In multiple myeloma, interleukin 6 is something which helps in the proliferation of the tumor cells, right? In myeloma, this interleukin 6 will be elevated because this is responsible for the cancer. It's responsible for the cancer completely, right? The plasma cells proliferate because of interleukin 6. Let's say that interleukin 6 in myeloma will be so high, so it will obviously increase fibrinogen. Let's assume the amount of fibrinogen increases 10 times. Can I expect the RBCs to settle even inside the body? I'm just having an assumption, that's all. If myeloma has more interleukin 6, it will obviously increase the fibrinogen. Can I expect the RBC to settle inside the body also? Yes or no? Is it possible? That's all. Just a hypothesis. You can say yes or no, it's completely fine. If you're wrong, it's completely fine. If you're right, it's also completely fine. There is a possibility, right? It might not settle inside the body, but definitely for me, ESR will be elevated, right? So let's take that. In a patient with myeloma, when I take a blood and I make a smear out of it, have you seen this? RBC stacking on one on top of each other in a peripheral smear of myeloma. What do we call it? Call it Roule, right? Amazing. So Roule is also due to fibrinogen. It's not due to multiple myeloma. It's due to the interleukin 6 in the myeloma which causes that. So why I wanted you to know, remember you this is, if you see in a MCQ, Roule formation, will you diagnose myeloma or will you diagnose inflammation? Myeloma or inflammation? I want you to always think of inflammation, be it an MCQ or be it a real life. Because inflammation, the incidence of inflammation is undoubtedly higher than in the incidence of myeloma. I'm not saying it cannot be myeloma at all, but it's interleukin 6. It's just simple fibrinogen, which results in your Roule formation. The Roule can be seen in inflammation, can be seen in malaria. When you have fever, take a peripheral smear and put it. To make it a smear, it will definitely show Roule. It just indicates the amount of inflammation, that's all. Right? I'll take your questions. Yes, Isra. It's predominantly based upon the fibrinogen level. See, what happens is amount of RBCs. RBCs also have an influence. Like you said, I'm having fibrinogen in my body equal to let's say 10 unit of RBCs. If the number of RBCs increases, the charge will not be neutralized much. If the number of RBCs reduces, again the charge will be neutralized faster. The RBC is also a variable. Fibrinogen is also a variable. The important component for me is fibrinogen. That's why in iron-deficiency and polycythemia, my ESR changes, right? Okay. We'll take Mikito's answer. If there's a decrease in fibrinogen, right? If there's a decrease in fibrinogen, he asks, will the ESR reduce? Let's assume there's no fibrinogen in the body. What do you think will happen to ESR? It's an open-ended question. Anyone can answer. There's no fibrinogen in the body. Let's give a disease name. We call it afibrinogenemia. There's a disease called as afibrinogenemia. What will happen to ESR? I'll have bleeding. There's no. I'm not going for the bleeding disorder, clotting disorder. I want in afibrinogenemia. What will happen to ESR? That's all. Will it decrease, or can I say with confidence it will become zero? It will definitely decrease. This is the only condition. It should be absent, not reduced fibrinogen. If it is absent fibrinogen, ESR will be zero. It will never ever sediment, right? That also is common in MCQ once. It's due to fibrinogen. If the fibrinogen reduces, ESR will reduce for sure. Fibrinogen increases, ESR will increase for sure, right? Yeah, I think I answered both of your questions. If you have any more doubt, you let me know. Okay, let's go through this question. Just have a look at this. Discuss something related to that. I'll keep quiet for the next 30 seconds. Comment on whatever comes to your mind, but I want you guys to comment on it. Any answers? Just make random answer. It's completely fine if you're right. If you're wrong, doesn't matter at all. I want you guys to attempt. That's more than enough. Okay, Bakashi has gone with C. Has gone with C. Mickey again. Okay, C. Great. Majority of you have gone with C. Great, right? So let's look at the gross image first, and then let's go and look at the history part as well. Fine. Looking at this gross image, just only one finding. Am I right in saying that the meninges, the meningeal covering, it's not clear. It's become kind of hazy and whitish in appearance. Yes, the layer covering the brain, it's not very clear because meninges will be clear. It will not be like this. It will not be hazy, right? So because this is attributed to the pus. So there's pus which is making the meninges look hazy, right? So it's a purulent exudate. That's what is happening in this condition. If it is purulent, I'm dealing with a bacterial cause of meningitis or a viral or fungal cause of meningitis. It's just pyogenic, right? If it's pyogenic, my predominant is going to be bacterial cause of meningitis. So I have ruled out two things automatically, right? So it has to be bacterial. It is pyogenic meningitis. So there are only two possible causes for me. Other things are possible still, but these two will have a more chance, fine? So let's take Mycobacterium tuberculosis versus Neisseria. I can solve this question with the help of my history or with the help of the gross image also. I'll try to solve it with the help of my gross image. Then we'll go to the history. When I see Mycobacterium tuberculosis, which part of the brain do you think will be more commonly affected? The convexity or the cerebral cortex or the base of the brain? Where will you have exudate in if it's Mycobacterium tuberculosis, base or convexity? Base or convexity? Imaging of Mycobacterium meningitis also will have the same clues. It's generally an basal exudate, right? It's generally a basal exudate, right? It's not the cerebral cortex. It's not the cerebral convexity, right? In general, fine. Right. So by looking at the image also, I can clearly say it's a convexity of the cerebral cortex, unlikely to be Mycobacterium. It's more favoring towards Neisseria meningitis, right? Now let's go to the history. 19-year-old kid, one, the young adult. Physical examination shows nuchal rigidity, that's completely fine. Skin shows petechial hemorrhages, and later the patient developed shock. So, shock, petechial hemorrhages might be due to your Neisseria meningitis, which would have caused adrenal hemorrhage. What is the syndrome I'm talking about? An adrenal hemorrhage, petechial hemorrhages, talking about great. Talking about Watrous Fredrickson, right? Great. So again, I'm confirming the fact. Yes, it has to be Neisseria meningitis, right? So it's just an image of pyogenic meningitis on the gross, and with the history of petechial hemorrhage and shock, I can narrow down to Watrous Fredrickson syndrome, which is secondary to Neisseria meningitis. It's and I might consider the young adult also as a factor because chance of transmission is more common in young adult compared to an elderly or a very kid, right? So these all points to one diagnosis, which is Neisseria meningitis, right? Okay, great. I think we'll call it off a session for today. If you have any more doubts, do let me know. I'll have one more session tomorrow as well, and same time 6 o'clock. If you're free, do attend and let's learn more things together. The final announcement: wherever you are from, try to attend the Unacademy QBank challenge. We have improved leaps and bounds in the QBank. I hope it will be helpful for your upcoming exams. The link is there in the Unacademy below this video as well as in the chat box. Bhagesh, you can ask me doubts in my group. You can, there's a Telegram group. I'll just type the group's name in the chat box. You can search in this. You can ask me in my Instagram page, or you can ask me in the Unacademy Telegram group as well. Fine. Okay. Anywhere, wherever I am seeing your doubts, I'll try to answer your questions. Thanks a lot. Thank you guys. Thank you for your time. See you soon tomorrow. Till then. Bye.